So I will now invite Dr. Bhupesh Singh. He'll be talking on laser-based procedures, safety and contraindications.
After this introduction, I'll be speaking on laser-based procedures, safety and contraindication for refractive surgery. So laser-based procedures are those procedures which are done by the laser to correct the glass power or specs. It's not working. Excuse me. Not working. मिल गया? Yeah, okay. So directly coming to the selection criteria for laser procedures. So whether you are doing PRK, whether you're doing LASIK, SMILE, all these laser procedures are almost have the same selection criteria. Although some procedures give some advantage with the pachymetry, like PRK you can do in lower pachy and LASIK you are not in lower pachy. So individual has to be 18 years or older. Although in last 5 to 7 years, I am seeing that almost 50% patients are not stable at 18 years of age. So I think we should change this trend of performing LASIK surgery at 18, and we have to be very careful because patients numbers are keep on increasing up to age 20, 21, 22. So try to delay these surgeries at least for 2-3 years more and confirm that whether number is stable or not. And the thickness as prescribed is 490 micron, and it works well for all the procedures, whether PRK, LASIK or SMILE. Absence of any significant ocular pathology. The most important is normal pentacam test, and common tomography has to be done in all the surgeries. No surgery is advised on the basis of CCT or pachymetry. Don't go for any surgery, any small correction also on the basis of pachymetry. Always go for the pentacam or tomography test. Residual stromal bed is a controversial value. So some studies are suggesting that you should go for 250 micron residual stromal bed after surgery. Some are 275, some said 300. So there is no consensus that what should be the ideal or the accurate residual stromal bed thickness. So what we do in our practice, we try to save as much as possible. The target is always 300, but for the mild myopic patients, we can go up to 275, but not less than that. This is another important concept that we all should know. That's a percent tissue altered. So whatever you are calculating should be feed in this formula, and if it is crossing 0.4, then we should avoid doing refractive surgeries, laser refractive surgeries, and shift to the lens-based procedures. And if it is less than 0.4 with a normal topography, we should go ahead with the laser-based procedures. These are the most important tools for performing refractive surgery, whether OpScan, Pentacam, Cassini. They are different and very good tomographers available in the market. So doing the procedure on these tomographers is one aspect, but understanding how to interpret these maps is more important than having these machines. So this is a OpScan map, and many centers are still doing surgeries on the basis of OpScan. Although this is a wonderful tool, but sometimes it miscalculates the posterior elevation. But definitely it's a good screen tool, and you have to do the centers 1.5 millimeter zone, 3 millimeter zone, then 5 millimeter zone, and see the irregularities. Then so we use Pentacam in our setup, and Pentacam is the gold standard right now in the country for performing laser-based procedures. So some basic point that we have to look always. So we have to see the K readings, K1 and K2. It should be less than 47.2, because once they cross 47, chances of ectasias are there. Then look for the central thickness. What is the central thickness? And the thickness difference between the central and the thinnest point. If thinnest point is too far from the center, then there is a chances of some ectasia. And so these are the three things that we have to see in these maps. And then the next map is more important, which shows the pachymetric progression, how the thickness is increasing from center to periphery, whether there is another abnormal jump or some skewing in the progression. So these values indicate those things: anterior curvature, posterior, and then this is the D value. If it is in white, then that means it's normal. If this is in red, absolute contraindicated for any laser-based procedures, whether PRK also. So this is another score that we used to follow before Entelman ectasia risk factor scoring. It is on the basis of corneal thickness, and you can calculate the score and then tell the patient that you are having this problem and you should not go for the laser-based procedures. The next, the newer classification is the ABCD system, where you see the radius of curvature of anterior and posterior curvature of cornea, thinness pachymetry, and best corrected visual acuity. And based on these parameters, you can classify the patient between low risk to high risk. So coming to the type of laser refractive surgery, the LASIK is the most commonly performed surgery worldwide, and there are basically two types: microkeratome based LASIK or femto flap LASIK. And the next procedure is PRK or surface ablation, and the newer procedure is KLEX, keratorefractive lenticle extraction. So laser is a laser assisted keratomiliosis. It reduces the glass need, and so the common power in which we do LASIK is starts from 0.5 diopter spherical to up to 10 diopter based on the patient's corneal thickness. If someone is having 580 or 600 pachymetry, you can go for -10 also. But if someone is having 510 or 500, you can go for 3 or 4 only. So it's totally a game of residual stromal bed, how much you're saving after the procedure. Hyperopia, although the results are not very good in high hyperopia, the advice is to go for not more than 5, because above that there are chances of regression. So we have to be very careful. Astigmatism management is very good with the iris tracker. You can go up to the -6 diopter of correction with the cylinder also. So in LASIK procedure is very simple. Just you have to make the flap with the blade or without the blade with the laser, lift the flap, do the ablation, and then deposit the flap. Surgery is very simple. Learning curve is not too much, but we have to be very careful while performing these procedures, because all these patients are 6 before surgery. So you should not deteriorate their vision after the surgery. So to start with the microkeratome LASIK, so there are different type of microkeratome available in the market. So they are very high precision oscillating blade system that dock into a suction ring to create a lamellar corneal flap while the cornea is held under the high pressure. So the machine creates a vacuum, it will hold the eye, and then you can perform the flap making. So it can be of two types: translational microkeratome, which creates nasal hinge, whereas pivoting system, which creates superior hinge. So both are equally good. There is no difference that this is good or this is bad, although the translational microkeratomes are easier to operate. So this is a translational type. Just keep putting after the docking, just keep putting the saline, and just straight from, you have to go from temporal to nasal side, and it's done. Lifting the flap is very easy in microkeratome because there is no adhesion, just you have to lift with any device. Important part is once you are starting to do the laser, always dry the surface. The surface should not be wet because it will hamper the delivery of laser on the stromal bed. So dry it. Always try to save the flap with from the excimer laser, especially in hyperopic cases where the ablation zone is quite big. So you have to save with the sponge and then deposit the flap, wash the interface, and deposit it. So coming to the femtosecond laser, so almost all big centers have moved to the femtosecond for almost all cases of refractive surgery nowadays. There are so many systems and almost all are very good. And in that there is no use of any blade. These femto systems are very advanced. And the best part with the femto system is that you can decide the thickness. With microkeratome, the accuracy of flap thickness is not very good. There is a variation of 10 to 20 micron in almost each case. But with the femto, there is no variation. If you decide for 110, it will be 110 only in the post-op patient. So patients who are borderline cases like 510 micron, 505 micron cases, so you need an accurate flap thickness so that the residual stromal bed has to be as planned. So femto works very well in borderline cases. Surgically, it's similar to blade LASIK only. So we use Visumax for all our LASIK patients. And this is the side cut, and then you have to lift the flap. With the newer laser system, the chances of adhesions and vertical gas break and all these things are very less nowadays, and surgeries become more predictable. So coming to the excimer laser, So excimer laser is more important in LASIK surgery than making a flap. So the term excimer is derived from the contraction of the word excited dimer, in which the argon and fluorine gases are used. And the goal is to reshape the cornea so that rays of light enters the eye and focus at the correct point of retina. So the first generation examiners were broad beam lasers, but now we are using flying spot lasers, and which are faster. They have the better iris recognition, so the astigmatism correction is very good in these flying spot laser system. So these are the different laser systems available in the market, from Wavelight to Schwinn, ML90 and Nidec. So, and almost all the systems are good. Some have some advantage, some different softwares for topo-guided LASIK, some don't have. So coming to the complication, there are n number of complications that can happen with the LASIK. All the numbers are very limited, and the common intraoperative complications like irregular or incomplete flaps, decentered flap, buttonholes or epithelial defect. And post-operative complication is flap dislocation in the immediate post-operative period. We have seen a lot of cases. The patient comes next day morning with a dislocated flap. Folds or striae are also sometimes there, although most of the striae you don't have to do anything. Those are micro striae. But for micro striae, you have to relift the flap and do the ironing. Epithelial ingrowth is another challenging situation to manage. Once you have the epithelium ingrowth, it's very difficult to manage. It takes a lot of effort to manage these cases of epithelial ingrowth. And the most dreaded complication after LASIK is post-LASIK ectasia. The important thing is you should know how to diagnose post-LASIK ectasia. So again, pentacam come into the picture to see the pattern of the ectasia in the zone of ablation, and rest area is flat, and this is the elevation in the center, which means that there is a post-LASIK ectasia. And coming to the the resurgent technique, that is PRK. We started with PRK and again came back to the PRK only. With trans-PRK, with mitomycin C, PRK is now very popular. In institutes like LV Prasad, they are doing more than 50% PRK surgeries out of all refractive surgeries. Places like Narayan Netralaya is also increasing their PRK numbers from 20% to 30% of all refractive surgeries. But big cities like Delhi, Bombay is still sticking to the lenticule and LASIK surgeries. So the pros of PRK is that it gives comparable visual outcome as LASIK or SMILE. It has lower, or you can say no flap, because there is no flap in PRK. Lower risk of ectasia because you are ablating less. So you are securing the corneal biomechanics post-operatively. Quicker and cheaper recovery, although it takes 4 days time to get the good vision or settled vision, but still in long run it works very well, and there is no learning curve, you can say, in PRK. There is a long list of complications, but in my experience, the main issue is discomfort or pain in early 3-4 days. Rest all are isolated cases. And another challenging problem with PRK was haze in the past, but with mitomycin C, the haze amount is also reduced significantly, but still once a while you don't know which patients behave how, and some patient still develop significant haze despite using mitomycin C. So that is a main problem. If we develop some device by which we can predict that this patient is going to get haze after any surgery, so we can avoid PRK in those patients. But still you can take the history of keloid formation, scar formation, but normally patients don't have all those things, but still they get significant haze. Some patients don't get any haze. So it's very difficult to judge who will get the haze, who will not get the haze. And regression is also reported more than LASIK in PRK patient. If you go for high corrections like 6-7 diopters, regressions are noted with PRK. And so this is the new technique that we are all shifting now, is lenticule based system. So this is a new terminology that have been proposed for all lenticule system, that is called KLEX. So KLEX is a keratorefractive lenticule extraction, and this is by JCRS now. So all SMILE, clear, whatever, it will come under the category of KLEX. So we should know the KLEX. So these are the current platforms that are in the market, and we have Visumax and Zimmer, both of them in our setup, and both are equally good. Both gives good results, although some cost factors are there in different machines, and almost all machines are coming with the auto-centration and cyclotorsion correction. All these things are coming in the newer machines, and results are become more predictable or not predictable in the post-operative period. So let's see the one SMILE procedure. So in SMILE, we usually take 110 as a cap thickness, and then lenticle is cut, and this is a 2.2 millimeter incision for entering. So first of all, you have to decide the upper plane and then go in the bottom plane. So plane identification is a challenge for beginners, but if you are a LASIK surgeon, it takes 2 to 3 cases to learn what is happening and how you have to manage. So there are different signs by which you can identify the correct plane, and then dissection. So with good optimized machine and with good surgical procedure, you don't need forceps to take out these lenticule. They comes very easily with this dissector only. So procedure is simple and but costly, and the machines are also very costly. Coming to the second part of the talk, which is when to say no for laser refractive surgery. So it's very difficult to say no to a surgery that is paying you good, but still we have to say no sometime. And the red flags are very young patients. So any patient who just completed 18 years, I try to defer the surgery for 6 months or 1 year and just see how the refraction is changing or not changing. Very high myo patients. So if you compare the result of ICL versus LASIK in these category of -8, -9, ICL patients are more happy than the laser patients. So my choice is always go for phakic lenses in 8, 9 or 10 diopters of correction. In topography, again, topography interpretation is very important. Any sign of skewing, thinning, or significant posterior elevation, we have to be very careful and very cautious before advising these procedures. Very high K reading. If everything is normal and patient is having steep cornea, 47, 48, high astigmatism but normal cornea, try to defer refractive LASIK surgeries, because they can be a form first cases and they'll become manifested after the surgery. Again, thinner corneas, 490, 495, 501, those patients are also, chances are there they will land up in ectasia in future. So we have to be very careful in those cases also. We can add up with the LASIK extra or SMILE extra to save these procedures from going in ectasia. Absolute contraindications, keratoconus. Any sign of keratoconus, straight no. Don't say that we can go with the LASIK or extra if there is sign of keratoconus. It's better not to do only. Go for the lens-based surgeries. Pupil size is another factor which determines the functional outcome of these procedures. The patient will get 6, but he will keep complaining about the glare and halos. So large scotopic pupil rule out LASIK if the optical zone diameter is smaller than the pupil itself. The treatment zone should be at least as large as the scotopic pupil and never smaller than 6 millimeter. Again, the thin cornea is not an independent risk factor, but if some patient has thin cornea or borderline cornea, but the correction needed is very high, so we should avoid those procedures. And again, the 275 micron is the target residual stromal bit in all these patients. And in thin corneas, biomechanics is another factor. We should look for biomechanics also, because chances are there that thinner corneas have the poor biomechanics, and by doing LASIK or SMILE, you are adding up to that. So better not to go for these refractive surgeries in these cases. Again, pregnancy and lactation, we should not do the surgeries at all. All those patients have this malar rash, SLE, or ocular surface cases. Better to avoid refractive surgeries because their healing is different from the normal individual. Herpes cases, many times we get patient with these herpes scars. It's very tempting to do the refractive surgery, but there are many case reports which tell that it can reactivate the herpes in post-operative period. So better not to go for the refractive surgery, go for the lens-based procedures. And dry eye is another important thing. As dry is on rampant in almost everybody is having some form of dryness in their eyes. So as we are doing pentacam for refractive surgery, dry eye is equally important before performing any laser-based refractive surgeries. So go for the complete dry evaluation. Take these history of isotretinoin and amiodarone, because these patients get more dryness in post-operative period. So any patients of epithelial basement membrane dystrophy, recurrent erosions, or any other form of dystrophy on the cornea, avoid the surgery, I have seen personally 1 or 2 patients, and doctors said to me that their epithelium is not healing. It's because again, the epithelium is getting detached, and those patients were EBMD patients. So you should be able to diagnose EBMD in pre-operative period, although it's slightly difficult, but can be done. Limbal vascularization, this is also very common in contact lens users, because most of our patients are contact lens users only. They're using contact lenses for correction. So this is a relative contraindication. You can make them off the lenses for a month or so, give them glasses, lubricant, nefazolin, all those things. Once this is settled down, then we should go for the refractive surgery. But because in this situation, if you go for surgery, chances are there that blood will seep in the interface, and then it will not come out. So deep-seated eye is another contraindication for lenticle procedures, especially SMILE. Then glaucoma, small palpable fissures, keloid scar formation patients, immunosuppressed or diabetes patients. So in conclusion, proper history taking and examination can help in correct decision making. Corneal tomography is an invaluable tool before planning refractive surgeries. No laser-based refractive surgery should be done without this. And all patients are not fit for refractive surgery, so choose judiciously. Thank you.